all of you.
Good morning,
Good
ma'am.
morning, ma'am.
Good morning,
Yeah.
ma'am.
Good morning, ma'am.
Yeah. So today we are welcoming to you to your first early clinical exposure hour in class setup of biochemistry department. So, or we call it as vertical integration also. That is, we are integrating whatever we have taught in biochemistry, some of the theory topics with clinical department. So today's topic for ECE, that is early clinical exposure, as per the curriculum, that is competency based medical education curriculum. You are supposed to have, it's compulsory to have early clinical exposure hours, both in clinical clinical setup as well as in class setup. So today's topic for ECE is Jaundice, a clinical perspective. So this topic will be taken by Dr. Aakash Thomas, the clinical professor in Department of Internal Medicine, AIMS Kochi. So, who is known to be an extremely good teacher and clinician. We are very thankful to him for finding the time amidst his busy schedule. So, over to you, sir. We welcome to you to this class.
Thank you very much, madam. Thank you very much for those kind words and introduction.
Thank you, sir. So please take the advantage of this class. Hopefully it will be very informative, and it is so you have to concentrate and just correlate the things which we have taught in biochemistry with what sir will be teaching to you. Thank you. Over to you, sir.
Thank you.
Okay.
Okay, welcome everyone to the class. Am I audible?
Yes, sir.
Yes,
Fine.
sir.
Okay, let this be an interactive class. Okay, first of all, I will congratulate you for getting the opportunity and the blessings to join this course. Understood? Being a doctor is really a blessing. And of course, it is both your effort and your parents' effort for you to reach this stage in your life. So make sure that you utilize, and you are lucky, blessed to be in a good institution like Amrita to do your MBBS. When you're doing your MBBS, whether you're going to be tomorrow a physician, a surgeon, a medical specialty, surgical specialty, research, academic, whatever it is, you're really building right now your basement or your building blocks. Understood. So to be in a good college like this again is I believe a blessing and a great opportunity. So my best wishes, congratulations, and keep doing well using this opportunity. Now, coming to the topic, I have been interested with talking about jaundice, a clinical perspective. Usually we come across when we start our clinical classes in third semester. Now this is the first time, I think not the first time, the second or third time that I am talking to you when this new syllabus has started in the recent past, that to give you an idea about you're in the first year, you are studying anatomy, physiology, and biochemistry. Many of you may be thinking that how is it useful with respect to clinical practice? In fact, what I feel is it is very, very important with respect to clinical practice. Very simplistically saying, what you're doing right now is building your basement. Whichever building you build, whether it's a villa project, whether it's a skyscraper, 1 floor, 2 floor building, whatever you're building, if it's a luxury project, whatever it is, you need to have a strong base. So right now, it may not be very evident, but you're really building a very strong base. It's based on that basement that you're going to be building whatever you're going to build tomorrow. That means in your clinical and in your professional practice, not clinical, professional practice, it is all going to be based on what you are. So how much effort you're putting in right now will be reflected in the future. Now, your teachers in physiology, biochemistry, in every subject have taught you about jaundice. So what I'm not going to teach medicine right now in 1 hour. It's not possible. What the aim of this class is going to be to give you an idea, to sensitize you. The importance of what you're teaching, what you're studying right now is going to be useful in clinical practice. Okay. Am I clear as of now?
Yes, sir.
Yes, sir.
Okay. Now, my next question is, what is jaundice? This is an interactive class. Don't worry. This is not going to be a theoretical full-fledged lecture, because that's already teachers, esteemed teachers in physiology, biochemistry, all are teaching you that. Anatomy, everything they're teaching you. My thing is to just sensitize you. So what is jaundice? What do you understand when somebody says a patient has jaundice? What do you understand? Anybody? Hello?
Yellowish discoloration of the skin.
Okay. Good.
Increased bilirubin level in blood.
Increased bilirubin level in the blood. Good. Continue. Let us bring it into the clinical perspective also. So if somebody says that a patient, what you said is jaundice is increased bilirubin, very good. Another person said that is discoloration, yellowish discoloration of the skin, very good. What else? If a patient has jaundice, somebody tells you there is a patient in the ward with jaundice. What else do you think in your mind? So far, good. Continue, please. Come on, 127 participants are there. I'm not hearing a single sound.
That could be a problem with the liver, so we could try to progress in that direction.
Okay, there could be a problem with the liver. Very good. What else? This is just a discussion. Anything else? Will it be, okay, my question is, will it be only a problem with the liver? If the patient has jaundice, does it mean that, yes?
Enzyme
Yes,
deficiency.
it could be enzyme deficiency. You mean enzyme deficiency in the liver?
Yes, sir.
Yes, so it's still in the liver only, right? My question is, can you have jaundice without any liver pathology or liver abnormality?
Yes, sir. Pre-hepatic jaundice.
Very good. Pre-hepatic jaundice. Understood? Okay. Anything else?
Obstructive jaundice.
Excuse me?
Obstructive jaundice.
Okay, that is again post-hepatic. It could be intrahepatic obstruction or extrahepatic obstruction. Very good. What else? I believe you have been taught about heme metabolism. You have been told about liver function test, correct?
Sir, increasing the level of SGPT and SGOT.
Okay. What I'm asking is, without liver involvement, as part of hemolytic anemia, you can have jaundice?
Yes, sir.
Yes.
Okay. Can you have jaundice in congestive cardiac failure? You can have. How is it possible? Congestive hepatitis, right heart failure, raised AVP, tender hepatomegaly, pedal edema, ascites. See, what I'm trying to imply right now is, or trying to emphasize to you people is that what you're studying right now in anatomy, physiology, biochemistry, I'm just applying that into clinical. So what it is just to emphasize the fact that what you're studying right now is very, very, very clinically relevant. Am I clear? So in congestive cardiac failure, because of the right heart failure, when you mean congestive cardiac failure, we mean right heart failure. There is pooling of blood in the liver and there is congestion of the liver, and you can have congestive hepatitis. Am I clear? You can have, like you said, as part of hemolytic anemia, it could be extra erythropoiesis, it could be something related to an RBC defect or extra corpuscular defect. Am I clear? It could be a membrane defect, it could be RBC enzyme defect, hemoglobin defect, or it could be that a condition where, like snake bite, you can have hemolytic anemia, malaria, you can have hemolytic anemia, drug-induced hemolytic anemia. You can have hemolytic anemia. Patients are predisposed to develop pigmented gallstones, so thereby producing cholecystitis. So you have calculous gallbladder stones resulting in calculous cholecystitis, and thereby it can produce jaundice. You can have patients with hemolytic anemia developing pigmented gallstones resulting in bile duct obstruction, and thereby producing, you can have obstructive jaundice. So if you look at the way it can be a straightforward condition, or it can be a simple thing going on to develop at multiple levels. Am I clear? in vitamin B12 deficiency, folic acid deficiency, iron deficiency, you can have ineffective erythropoiesis and thereby early destruction of RBCs and thereby resulting in hemolytic anemia. So various ways in which, understood. Okay, so someone had told me jaundice. So let's go into what I'm going to do is using what you have been taught so far, heme metabolism and your liver function test. I'm going to describe the usage of this in the clinical practice. Okay, jaundice is a common clinical problem. We have a lot of patients coming in either as an outpatient visit or an inpatient with patient as patient presenting with jaundice. Like you have, I believe all of you have studied the heme metabolism pathway, right? The bilirubin metabolism pathway. Yes? Yes?
Yes.
Okay, so I'm going to use that pathway and tell you about these things. It can be caused by bilirubin. Whenever you have a patient with jaundice, you have to think of various possibilities. You have to look at the patient as a whole, take the history, physical examination, and accordingly relevant investigations and come to a conclusion. So it can be caused by, as you have studied, bilirubin overproduction. Like I told you, hemolytic anemia, ineffective erythropoiesis, drug-induced. It could be due to impaired bilirubin conjugation. It could be due to biliary obstruction. It could be due to hepatic inflammation, like a common condition like acute viral hepatitis. Now, when you say a patient has clinically evident jaundice, do all patients with jaundice is elevated bilirubin, do all patients, will they have clinical jaundice?
No, sir.
Yes, correct. Usually the standard books give it as when the bilirubin is more than 2 to 3. Most books give it as when it is above 2 or above 3. No books, standard books do not say less than 2. It is very difficult to appreciate clinically jaundice. Now, when you look for jaundice, I believe you know that you're supposed to look in the sclera, the underside of the tongue, the oral mucosa, the palm, soles, and skin. Why is the sclera, whenever you're taught, you're always asked to look first in the sclera? Why is that? Anybody?
Because it is highly vascularized.
It is because of the increased elastin content of the sclera, which has a high affinity for bilirubin. Okay, fine. Next, what is keratinoderma? For those who are interested, what is keratinoderma? What I'm trying to imply is every yellowish discoloration is not jaundice. Any idea? It's given in the slide.
Perhaps as increased beta carotene.
Yes, correct. As it's given in the slide, it is presence of increased carrot. So if a person is having increased consumption of carrots, leafy vegetables, peaches, oranges, what happens is there is an increased keratin content in the body. It can mimic jaundice. But the clinical clue is patient can present with yellowish discoloration, especially unlike jaundice, which has equal affinity for every part of the body. Keratinoderma, where there is increased keratin content in your blood, is present predominantly over the palms, the soles, nasolabial folds, and the forehead. A very important thing is, unlike jaundice, where jaundice starts first in the sclera, here it spares the sclera. Understood? In keratinoderma, there is sparing of the sclera. Clear? This is just for your information. Now, let us go by your. I'll go back to the first slide, and we'll start off with. I would like it to be an interactive heme metabolism pathway. Can you tell me the heme metabolism pathway? Anybody, just start off. Then we will. Each one can contribute. How does it start? I just want you to have the clinical application in each stages of that heme metabolism pathway. Come on. 132 participants, and all of you are sitting just like that.
So lifespan of RBC is 120 days, and then the lysis of RBC releases hemoglobin.
So the lysis of old RBCs, 120 days. After the 120 days, the old RBCs are destroyed and new RBCs are produced. Continue. Very good, madam. Continue.
Then hemoglobin breaks into heme and globin.
Where is that
And,
taking place?
Reticular endothelial system.
Very good. Where is that? Very good. Where is that?
Liver.
Liver and predominantly in the spleen. Okay, very good. This is a normal physiological thing. It's not pathological. It's normally taking place. All of us. Okay, good. Continue.
Then the globin get accumulated in the amino acid pool in the body.
So you have increased destruction. You have not increased normal destruction of old RBCs. 85% of this is because heme is by the old senescent RBCs are destroyed. Okay, then in the spleen, then what happens? Next step, what happens? Because it's important what you have studied is each stage into the clinical part. Next, what happens? So far, good. Continue. I told you we don't want to take again a theoretical class. It's just emphasizing or application of what you have studied.
So then the heme is converted into biliverdin.
Okay, very good.
And the biliverdin is transformed into bilirubin by biliverdin reductase.
Very good.
And the bilirubin is not soluble in water.
Okay,
That
shall
is,
we stop at this stage and I'll just describe the thing and then we'll proceed further? Okay.
Yes, sir.
Okay. So one, you said very correctly, old RBCs are destroyed. Bilirubin is produced, biliverdin, which is converted into bilirubin. Very good. At this stage, it is unconjugated bilirubin, right? So at this stage of the thing, if anything happens, you're going to have increased bilirubin, right? So what are the possibilities? One, old RBC is destroyed is occurring at the normal physiology. Something pathological has to take place. That is, one is hemolytic anemia. That means the RBCs are abnormal. It could be abnormality in the RBC membrane. It could be in the enzymes. It could be at the hemoglobin level. Whatever corpuscular defect is there, because they are considered abnormal, as they pass through the spleen, they are destroyed rather than at every 120 days. They are destroyed much earlier. So you have bilirubin overproduction, which is unconjugated hyperbilirubinemia. Or in other words, like I said, the RBCs are normal, but because the raw materials, that is vitamin B12, folic acid, iron deficiency is there, what will happen in a patient with iron deficiency, anemia, all those things? They'll have ineffective erythropoiesis. The RBCs that are produced are not good enough, so they can be destroyed. Or you can have toxins like snake bite, or infections like malaria, where parasitized RBCs are destroyed area. You're traveling to Tamil Nadu, Karnataka, North India. In Kerala, it is not very common, but when you travel to the other parts, North India, any other parts of India, you can be bitten by a mosquito and develop malaria, high-grade fever, chills, rigors, along with that jaundice. So because of the parasitized RBCs are being destroyed, there is bilirubin overproduction. Fine. Various drugs can produce unconjugated hyperbilirubinemia. Drugs can produce drug-induced hemolysis. Am I clear at this stage? Okay. Shall we proceed? Madam, continue.
So then the bilirubin get conjugated.
Before conjugation, what happens, madam? The unconjugated bilirubin has to reach the...
binds
Yes.
with albumin and then reaches the liver.
Yes. So it has to bind to the albumin, reaches the liver. Fine. Then what happens there?
There in the liver, it gets conjugated by ADP glucuronide transferase.
1 minute, madam. 1 minute. Before the conjugation, it has to be, liver uptake has to take place, right?
Yes, sir.
So liver uptake, what happens? The albumin is released back into the bloodstream and only the albumin is taken up. Only the bilirubin is taken up by the liver, right? It's not the, yes, very good. Fine. So again, the next stage is uptake. Any abnormality in the hepatic uptake of the unconjugated bilirubin and also result in increased bilirubin, right? Yes, continue, madam. Please continue.
Yes, sir. And then the bilirubin is conjugated in the liver by the enzyme UDP glucuronide transferase, and then from the liver it gets transported to the intestine.
Okay, 1 minute. So you said very clearly that now that unconjugated bilirubin is getting conjugated in the liver, right? So any defect at this stage also, if there is a defect in the conjugation pathway, you're going to have unconjugated hyperbilirubinemia. Can you tell me of any conditions that can produce at this level? If the conjugation, any disorders that you know of, I'm trying to apply it into medicine. That is why. Clinical practice, clinical perspective. Have you heard of Crigler-Najjar syndrome, type 1, type 2 syndromes? Crigler-Najjar type 1 syndrome, there is complete absence of conjugation deficiency. So what happens? Increased bilirubin, kernicterus, the child does not survive. While Crigler-Najjar type 2, the child can survive into adulthood because there is relative deficiency, not absolute deficiency. Understood? Then you have something called as at this level, other symptom known as something that you're going to see every day in your clinical practice, every day in various ways. One is Gilbert syndrome. Anybody knows what is Gilbert syndrome? It is a defect in the relative defect, 3 to 7% of normal population. That means what I'm trying to say is that 3 to 7% of normal population can have something called as Gilbert syndromes. Males are more common than females. In other words, among the 132, 136 participants right now, some of you may have Gilbert syndrome. That is not an abnormality. Only when you are coming to the hospital for some other reason. For example, you come for an unrelated fever and you find unconjugated bilirubinemia, or for some other illnesses when you alcohol overuse and you are coming to the hospital for that reason, you find that unconjugated hyperbilirubinemia, or during starvation, stressful situation, during fasting, the bystander, your family members may notice that there is a little yellowish discoloration of the sclera. That is when they come to the hospital, they think that it is, and they are worried that unfortunately, even in the layman knows that if there is an yellowish discoloration of the eyes, most likely liver is damaged. So they come to us. When we look, everything is normal. It is just that there is a impaired conjugation. So there is a mild hyperemia, which will always persist. Nothing is to be done for that. Every other parameter, patient will not have history, physical examination, or lab investigation findings of liver damage at all. This is something that we commonly see. Understood? Okay. So I'm just giving you an idea at various levels. Rifampicin, so various drugs, commonly used anti-tuberculous drugs, all of this can impair this impaired bilirubin conjugation. Okay, madam, continue please. I'm trying to, at each level of your pathway, give you a clinical perspective. Continue, madam, please.
Sir, after transportation to the intestine, it is acted upon by the bacteria in the colon.
How does it reach the intestine, madam? Very good. How does it reach the intestine? Because the third line, the biliary obstruction. Now onwards, you're talking about the obstruction to the passage. That is very significant. That is why I'm telling. Tell me,
biliary duct.
Very good. Intrahepatic bile duct, extrahepatic bile duct, common bile duct, draining into which part of the intestine? Duodenum. Okay, it drains into the duodenum. So if there is an intrahepatic obstruction or bile duct obstruction, whatever it is, it could be malignancy, it could be a bile duct, it could be hepatic inflammation, intrahepatic cholestasis, it could be the bile duct abnormality, structural abnormality of the bile duct, intraluminal obstruction like a stone, malignancy. Then the second part of the duodenum, the periambulary malignancy, cancer, any of these things can result in biliary obstruction. Okay, continue, madam. And thereby resulting in, now when you develop it, it will be conjugated hyper, because the conjugation has taken place. Now it's occurring after that, so it becomes conjugated hyperbilirubinemia. Continue, madam.
Yes, sir. So then it is converted into urobilinogen in the intestine and then excreted through urine
by the gut flora. Okay, it is converted by the gut flora. Okay, urobilinogen. It is excreted in the
urine.
Okay. So what is the significance of this urobilinogen in the urine?
It gives a yellowish color of the urine.
So what I'm trying to say is that if you have conjugated bilirubinemia, that means bilirubin is elevated and it's conjugate, the patient will say yellowish color urine. Clear? While if it is a condition like hemolytic anemia where you have unconjugated bilirubinemia, which is, like you said very clearly in the beginning, water insoluble. That is why it is bound to albumin to reach the liver. If it is water insoluble, urine will be not yellowish in color. Clear? So absence of bilirubin in the urine in a patient with jaundice gives you an idea that I am dealing with unconjugated bilirubin. While conjugated bilirubin, you will have bilirubinemia. Continue, please. Next, what happens, madam?
Some part of the bilirubin is excreted to stool as stercobilinogen.
Very good.
It gives a brown color of the stool.
Yes, that is the one clinical significance is stercobilinogen, brown color to you. So what happens if stercobilinogen is not present in the stool?
Clay colored stool.
Yes, where do you see that?
Pre-hepatic jaundice.
No, in pre-hepatic jaundice, there is no obstruction, right? Normal jaundice is reaching. It is a biliary obstruction. So conjugation has taken place, but intrahepatic obstruction, extrahepatic obstruction, bile ducts obstruction, whether it is stones, calculi, malignancy, strictures, whatever be the thing, duodenal obstruction. So it is not reaching the intestine. What happens? The patient is not going to have stercobilinogen in the stools. When you do not have stercobilinogen in the stools, you're going to have pale, bulky, pale stools. Understood? So pale stools go in favor of obstructive jaundice. So that is why, to differentiate, am I dealing with jaundice, hepatic jaundice or obstructive jaundice, you ask the patient, do you have what? Does anybody know what are the other features of obstructive jaundice? Using the metabolism and using what you have taught so far, what you have been taught so far by your teachers, I am just using it and putting it into or emphasizing the clinical perspective. 1, you're going to have increased jaundice. 2, you're going to have pale colored stools. 3, because of the increased bilirubin in the blood, you're going to have pruritus. In fact, one of the non-dermatological, see, when you have a skin infection, when you have skin manifestations, you can have pruritus. These are the systemic causes of pruritus. That means skin is normal, but you have systemic manifestations like obstructive jaundice. So bilirubin deposition. This results in pruritus. Clear? Any doubts at this stage?
Sir,
Anybody? Any doubts at this stage?
sir,
Yeah.
excuse me.
Tell me, madam.
I just remember when we were talking about pale stool, I remembered like in cholera, we get really pale rice water colored stool. So is there any sort of relation between these, or is that?
No, madam. In cholera, rice water stool, and when I'm saying pale color stools, we are talking about not the consistency of the stool. We are talking about the color of the stool. In cholera, you are definitely not going to get this type of pale colored stools.
Okay.
Secondly, one more thing that you're going to have, I had mentioned it earlier, but I'm going to clarify that now once more. Steatorrhea. What is steatorrhea? Fat in the stools. Understood? So you're going to have pale, bulky, foul-smelling stool, which cannot be easily flushed away. This is the characteristic description of obstructive jaundice related. Not only pale, you're going to have bulky because of fat in the stool, foul smelling because of the large fat content in the stool, and because if like oil on water, it will float over the water. Pale, bulky, foul smelling stool, which cannot be or the patient says or the bystander says, it cannot be easily flushed.
Right.
Understood. So when all these things together come, that is when we consider obstructive jaundice. Now, next thing what I would like to emphasize is what are the physiological or the role of liver with respect to normal functioning of the body. That is again response that's important for clinical person. That's how we take the history, physical examination findings. All of this are basically when you know the normal physiology, you just look at each level of that physiology, biochemistry pathway, you decide what are the abnormalities, what step. That's how we went right now. Each step, the abnormalities that are taking place results in clinical picture. So what is the role? What if somebody says, if a bystander comes and asks us, or a patient comes and asks us, doctor, what is this importance of liver in the body? What role does it play in my body?
So carbohydrate metabolism, glycolysis, glycogenolysis, gluconeogenesis.
Very good. Continue.
And in protein metabolism and fat metabolism also.
So carbohydrate, fat, and protein metabolism, liver plays a very important role. Very good. Somebody was telling something else in between. Please tell. Could you repeat it? It is the correct thing. Could you repeat it, please?
Detoxification.
Detoxification. That means it acts also as a. That's why I tell my patients when they ask me, I tell them that it acts like a. Okay, I'll mention that last. Detoxification. Very good. It is either about that means it's got an excretory role, just like renal. Liver also plays an different role. With respect to, and when you say the metabolism, please add also the metabolism of the various drugs you are taking. That is why whenever we give medications, we look at three things. One, geriatric population. 2, is a patient pregnant or lactating, that is breastfeeding. 3, is there any liver disease and renal disease? This is very important because majority of the drugs are metabolized either exclusively or partially in the liver and the kidneys. Understood? So one is including drugs or toxins like alcohol, metabolized by the liver. Various drugs, various poisons, various food substances. Okay. What else? Whatever you have studied only, I'm asking. Anything else the liver does? Is there any production taking place in the liver?
Erythropoiesis.
Okay, it's got a minor role in the erythropoiesis. Yes, that is why you have anemia as part of liver disease. Very good. Then
plasma proteins.
Yes, protein production. That is why you have hyperproteinemia in liver disease and thereby patient developing edema as part of liver failure. Very good. Continue.
So increased alkaline phosphatase.
Increased alkaline phosphatase is liver disorder, right? I said normal. Yes, what you're trying to say, alkaline phosphatase is a source from the liver other than intestine, placenta, bone. Very good. So any disorder, when you have an elevated alkaline phosphatase, you have to consider a liver pathology. Very good. Anything else? Coagulation factors. Does the liver have a role in the coagulation factors?
Yes, sir. Prothrombin.
Okay. Very good. Immunoglobulins. Definitely, there is. So that's why I tell my patients, see, everybody understands the seriousness of a heart. Everybody says if heart attack is there, heart failure is there, layman understands that it can be dangerous. It is a very vital organ. Same way with the liver. Understood? Liver plays a role in the production. Liver plays a role in the metabolism. Processing plant, it plays a role as a processing plant. It plays a role of a waste treatment plant. It plays the role of a bank. It stores something. Anything does it store in the liver?
Vitamins.
Yes, your iron, vitamin B12, folic acid. Understood? So liver has multiple roles. Now, what is the significance of this is, if any of these are disrupted, whatever be the etiology, whatever be the reason of the liver damage, if it is disrupted, you're going to have multiple problems that can manifest in the clinical history or the physical examination. One of it is jaundice. Bilirubin is only one aspect of the liver. There are multiple other roles when you look at your physiology and your biochemistry. You're going to understand that there are multiple roles of liver, which at each stage, if you just take it and see if this is impaired, what is going to happen? If this is impaired, what is going to happen? That is the clinical perspective I'm giving you. So if you need to understand the pathology, you definitely need to know what is normal. Only then can you understand what is abnormal. Am I clear?
Yes, sir.
Okay. Now, based on this, let us go. As a doctor, as a physician, as a clinician, any doctor, first thing is we always take history. Then we do physical examination of the patient. Then we do the relevant investigation. This should be the order. It's not jump and do the investigation and then look at the patient. History, physical exam. Now, why should we go in this order is, when you take a history, what is happening is the patient is giving you so many clues. Am I clear? The patient, he or she is making your job easy. You are asked to see this problem alone. You don't have to think that the whole of medicine, the whole of surgery, whole of gynecology. Patient comes and tells you, I have fever and running nose. You don't have to worry about leg pain. He's giving you a clue that my problems are focused in the upper respiratory tract. Understood. Second thing, by taking a history, not only it's making your job easy, the most important thing, a doctor-patient relationship is a rapport. So how do we develop a rapport? A very simple thing is communication. And in the communication, it is listening to the patient's problem. So history is listening to the patient's problem and then taking relevant questions regarding that, correct, getting with your knowledge, you are applying that knowledge and getting more and more information about things to come to a conclusion. So when a doctor is listening to a patient, what happens is immediately, because the most important thing between two people, forget about doctor, patient, anybody, is communication. And the most important thing about communication is listening. So by taking history, you're listening to the patient's problem, analyzing that relevant history. So he or she becomes happy that you are listening to what is their problem. Once you have listened to their problem, you have made a history that is in the base of chief complaint, history of presenting illness, past history, past personal history, treatment history, family history, drug history, leeway and travel history, pet history, and the various headings under which you're going to collect information. Then you go into the examination. So you have taken history. Now you examine the patient. So once you have built a certain rapport, you take the permission of the patient and examine the patient in the appropriate way, relevant physical examination. Once you have reached this, you come to an appropriate, sometimes you get, with the history level itself, you'll get a conclusion. Sometimes you need a history and physical examination to come to a conclusion. Sometimes you're not able to conclusion, maybe from 10 possibilities, you have narrowed it down to 1 or 2. Now you do finally investigation. In this era, investigations have an important role. I'm not saying they don't have a role. They definitely have a role. But if you take it in the context of a proper history and a proper physical examination, it becomes relevant investigation. The patient will trust that you have done your job and you're going to not misuse the investigations. He's already felt that you're doing your job. They're not going to come in front of you and ask, how much marks did you get in anatomy? How much marks did you get in medicine, surgery? No, where did you pass out from? They're just trusting that the doctor will do a sincere job. And how do we do a job? The sincerity, doing our job the right way. That is taking a proper history, taking a proper physical examination and relevant investigations. Investigations are important to confirm our diagnosis. Taking all this is not sufficient. You have to confirm. In this era, definitely you have, when you have tools, we are dealing with patients' life, we definitely have to confirm. The confirmation may be in the form of that confirming that this is the thing or excluding certain things. And finally, the relevant or the specific treatment of the patient. Am I clear? History, physical examination, investigations, and then treatment. Clear?
Yes, sir.
So what you're doing right now is you're building the basic blocks of knowing what is normal about human being. And then thereby you will know what is, then you go to the next step based on that normal and learning of the abnormal. You're able to do these steps of history, physical examination, investigations, and treatment. Now in a conclusion, because it's a clinical perspective, what are the symptoms that if a patient with jaundice comes to you, what are the other symptoms that the patient can have? I'm not going too much detail into the other parts that as you come to the next semester, we will definitely teach you. But just to give you a clinical, so that I am emphasizing what you're teaching, what you're being taught right now by your teachers. What this class is basically to emphasize the importance in practice as a doctor. Please tell me, what are the possibilities? Now with that, we have gone through what are the normal functions of the liver, what is the normal pathways, what is the history the patient could have, a patient with jaundice could come to you with. Anybody? Don't worry if it is right or wrong, don't worry about this, just an interactive class. Anybody? One 39 participants and nobody is ready to open the mouth. Come on. Don't worry if it is right or wrong. That's not a thing. It's just to interact. Then only all of us get involved. Otherwise, it'll be just like a lecture class.
Fatty liver can come?
Yes, madam.
Fatty liver can come as a history.
Fatty liver is a diagnosis, right? Patient is not going to come and tell me that I have fatty liver. That somebody has done an investigation, so patient can come to you, correct? Because when you may be not the first doctor to see the patient, already somebody has seen the patient, now they come to you for a second opinion. So in that way, yes. But otherwise, what are the?
Fatigue.
Very good. Fatigue. When you have so much of role played by the liver from the production side, metabolism, excretory, storage, so many functions of the liver. Any of these, one symptom can be just fatigue, weakness. Okay, very good. Two. Since you said fatigue, can anybody tell what will be a specific feature of fatigue with respect to liver disease compared to other fatigue conditions? I'll give you a clue. You had told me that carbohydrate metabolism is taking place in the liver. Okay. So what is the specific thing about the fatigue that the patients can complain that you get a clue that this is most likely this fatigue is due to liver disease based on the carbohydrate metabolism? Shall I answer?
Sir, glucose level go down.
Very good.
That's why the patient feel tired.
Yes, what I said is, what else can the patient talk about the fatigue, which gives you a clue that I could be dealing with liver disease? I'm not talking about any other associated symptoms, specifically the fatigue. What you said is correct. Liver is the site of glucose production, glucose storage. So that's why I'm giving that clue based on that. Okay, I'll give you a clue. Diurnal variation, morning, evening. Will there be a variation liver disease? Shall I answer? Or do you want to answer or shall I answer? Hello?
Yes, sir.
Okay, I'll answer. You said very clearly and very correctly that liver is the site of carbohydrate metabolism. And one of you said very clearly the various steps of liver carbohydrate metabolism. So storage, production, all those things, utilization, everything. So what happens? What is the fuel for us to do our work? Glucose, right? So when the carbohydrate metabolism is affected, the patient says that in the morning when I get up, doctor, I feel better. But by the time as the day progresses, by the evening, I feel the fatigue is much more in the evening. Because when there is a liver damage, the liver stores, the carbohydrate metabolism is impaired. The liver stores of glucose, glycogen, all those are impaired. So a little bit of activity utilizes the fuel. So by the time the patient reaches evening, he or she feels much more worsening. Clear?
Yes, sir.
So you're understanding how whatever you're studying is being utilized in clinical medicine. Continue. What else could be the symptoms? One is fatigue. Very good. Then
The clay-colored stools.
Clay-colored stools. Good. Continue.
The weight loss.
Weight loss. Yes, definitely. Depending on if it is a chronic condition or if it is a serious condition, weight loss can happen. What else?
The itching of the skin.
Very good. Pruritus, obstructive jaundice. You can have clay-colored stools. You can have pruritus or itching. Very good.
Suppose as
Dark
hemolysis.
yellowish urine.
Tired feeling, weakness. Yes. What else, madam? Somebody said.
Sir, yellowish urine.
I didn't get you, madam. Urine what?
Yellowish, dark yellowish.
Yellowish color urine. Very good. Bilirubin in the skin, mucous membrane, body tissue. So bilirubin, urea, you will get yellowish color urine. Somebody else was saying something, please. Hello. Okay, I'll just put it up the slide. One is the patient can come. Yeah, tell me.
No, I was just wondering, since hemolysis can occur, could there be any sort of maybe fever or something like that?
Yes, depending on the cause of if it's malaria causing hemolysis, you can have fever.
Yes, anemia.
Yes, definitely. You can have symptoms of anemia, that is weakness, fatigue. Understood?
Okay.
The classical symptoms are one is jaundice, patient coming to you or the bystanders noting jaundice. It could be in the skin, the mucous membrane, the sclera. It could be in the urine. The stool color, like you said clearly, when there is obstructive jaundice, the patient can have pale, bulky, foul-smelling stools, steatoria, or depending on the severity, it could be just pale color stools, or as the severity increases, it can be bulky, foul-smelling, difficult to flush, the classical steatoria symptoms. Patient can have pruritus because of the coagulation factors being produced there. If there is liver damage, patient can have bleeding manifestations. Patient can have anemia due to hemolytic anemia. Irrespective of the thing, anemia itself can produce symptoms. Patient can have liver disease, chronic liver disease, or hemolytic anemia because of increased destruction, splenomegaly is there. Thereby, they can complain to you that they are having a dragging sensation in the left hypochondria. Or if there's a massive splenomegaly, cirrhosis with portal hypertension, massive splenomegaly, they can tell you that because of the spleen pressing onto the stomach, early satiety. That means when they eat a small quantity of food, there is a sense of fullness. They can have anorexia, decreased appetite, nausea, vomiting, right hypochondral pain. Then depending on the complications, you can have ascites. Like somebody was saying, detoxification, processing, everything. So what happens? Hepatic encephalopathy, acute liver failure patient can have alteration of sensorium. The bystanders will be telling you that the earliest thing that they notice, or the symptom they are noticing, is that the patient is sleeping, inversion of sleep rhythm. That means patient sleeps in the night, in the morning, and is awake in the night time. Inversion of sleep rhythm. So multiple symptoms depending on each level variety. Then if there is an infective cause, the patient can have fever. Sometimes because the liver gets a large amount of blood, out of the cardiac output, a huge amount goes to the liver. So what happens? Different parts of the body, liver is passed in different parts of the body, the blood is passing through the liver. Secondaries, liver is a common site for secondaries. That is, there is a malignancy in some part of the body, and there is secondary spread of the malignancy to the liver. Thereby, they can have metastasis to the liver and presenting with liver involvement. When you start going backwards, you finally reach the conclusion that this is a secondary and the primary is sitting somewhere else. Understood. Examination wise, obviously, we will look for jaundice, pruritus marks on the skin, bleeding manifestations on the skin. We will look for liver. We will look for spleen. We will look for flapping tremors as part of hepatic encephalopathy. And then depending on what we think, accordingly from top head to foot, we will look for specific investigations. Now, finally, we go to the investigations. In the investigations, anytime when you are having jaundice, the first thing is liver function test. What are the components of liver function test? To conclude, next 5 minutes, I'll conclude. What are the what are the components of liver function test? Anybody? I believe you have been taught the components of liver function test, right? LFT, liver function test. Come on, let us. So far you are contributing. So let us, anybody?
So hepatic marker.
Very good. The first thing is hepatic marker.
Taste for bile pigment and bile salts.
Okay. Anything else? As part of the liver function test, the first thing is bilirubin. We look at the total bilirubin and the direct and indirect. So that means conjugated and unconjugated. So we would like to know, whenever you have jaundice, we are expecting a clinically jaundice. I told you, even before you're doing the liver function test, you're expecting that the bilirubin must be 2 to 3 and above. Now, that's not enough for us. We want to know, is it conjugated bilirubinemia or unconjugated? So you know the total bilirubin, the direct and indirect, that is a conjugated and indirect. Next thing is you want to know, is it only the bilirubin that is elevated? Like I told you, it can be at the conjugation level and all, or is it a liver disease? If it is a liver disease, the next thing is you look at the various other components of the liver function test, that is SGOT, also known as AST, STPT, also known as ALT, alkaline phosphatase, ALP. These are the liver enzymes. So if they are damaged, obviously they are going to be elevated. Now your clue that you get is, am I dealing with an obstructive jaundice or a non-obstructive jaundice? In obstructive jaundice, the alkaline phosphatase will be elevated more than 2 to 2.5 times the normal. While AST-ALT also will be elevated, they'll be only mildly elevated. Next thing that you look is the albumin globulin, because albumin is produced by the liver. The half-life of albumin is around 21 days. So if you find that there is hypoalbuminemia, not only does it give you an idea that it is a liver damage, it gives you an idea that this is a chronic liver damage. It's going on for more than last 21 days, more than 3 weeks it's been going on. Then, as part of the bleeding manifestations, you look at the PTIN, prothrombin time, like somebody had said, the coagulation factors are produced. So, as part of physiology and biochemistry, you must have known the half-life of the coagulation factors. So, you know that within 24 hours, if they are not replaced, the INR is going to be prolonged. So it gives you an idea again that there is an acute worsening of liver disease. Albumin gives you an idea about chronic liver disease, while PTINR gives you an idea about acute liver disease. Then you look at, like somebody said clearly, urine. Whenever you have bilirubin, you want to know, is it conjugated bilirubin or unconjugated? If it is conjugated, you are expecting bilirubin in the urine. If it is not there, it gives you an idea. Achloric jaundice, it's known as, that means it is unconjugated, which is water insoluble, which will not be present in the urine. Then you look at the urine for urobilinogen. In obstructive jaundice, urobilinogen will not reach the urine, so it will be absent. While in hepatic jaundice and prehepatic jaundice, urobilinogen, there is increased production, so there is increased urobilinogen in the urine. So these are the clues that you give. Is it conjugated or unconjugated? Is the liver function, rest of the liver function involved or not? To give you an idea, is it a hepatic jaundice or a prehepatic jaundice? If there is a hepatic cause of jaundice, next thing you want to know is the patient having urobilinogen? If there is absence of urobilinogen in the urine, it gives you an idea it is obstructive jaundice. Prehepatic jaundice and hepatic jaundice, the urobilinogen will be increased, while in hepatic jaundice, it will be, in post-hepatic, that is obstructive jaundice, it will be absent. Understood? Then based on this, if you are suspecting that the patient has a hemolytic, that is increased destruction, you look at the CBC to see anemia is present or not, complete blood count. You see reticulocytosis, increased reticular, as you must have heard, you must have read in physiology and biochemistry, that if there is destruction, the body tries to compensate by increased erythropoiesis, so there will be reticulocytosis. You look at the peripheral smear to see the RBC defects, what type of RBC, is it microcytic hyperchromic? You do the various, then depending on that, you go for the LDH level to see increased destruction. You look at ultrasound is done to see if there's presence of gallstones, is there any liver abnormality, size of the liver is enlarged or the size of liver decreased, the echo texture of the liver, complications of liver like splenomegaly, ascites, and various other things. Am I clear at this level? History taking, the physical examination, the relevant investigations, how we are using even right now in our practice, even in a very high-tech hospital like this, how what you're being taught right now, we are just applying it into clinical practice. Am I clear? Any doubts?
Sir?
Yes, please.
So in chronic liver disease, can there be muscle damage?
Definitely, Guta. There can be muscle damage. It depends on what is the reason. Understood. See, in muscle, what happens is when your carbohydrate, protein, fat metabolism are impaired, what happens? Muscle wasting can occur. That is why you find patients with chronic liver disease, that is cirrhosis and all, they are going to have a protuberant abdomen because of ascites, but you will find that they're going to have pigmented skin. They're going to have emaciated, that means their legs, hands and all will be emaciated, muscle wasting will be there. If you ask them, they will say that initial stages, when, for example, alcohol consumption, initial stages, they were very hefty built, they were well-built people. The family members and the patient will say that now it is like pencil-like hands and legs and only the abdomen is protruding. That is because of carbohydrate, protein, fat metabolism. In addition to that, because of the chronic liver disease, the patient's food intake is decreased, protein malnutrition, all those things will contribute.
Okay.
Any other doubts?
Sir, if a person donates part of their liver, will the donor experience any jaundice, sir?
At all very fancy, because of one very good, important capacity of the liver is to regenerate. Understood? Am I audible?
Yes, sir.
Yeah, that is why donors can, unlike giving the kidney, if you're donating a kidney, that much is lost. You're always then single kidney. But with the liver, the thing is, liver has a huge potential for regenerate. Up to a certain stage, it will regenerate. That is why, for example, a person is consuming alcohol. It doesn't immediately reach cirrhosis. Alcoholic fatty liver, alcoholic hepatitis, alcoholic, chronic liver disease, cirrhosis, and then hepatocellular carcinoma. So till that stage of cirrhosis, even they say that now the literature states that even in the early stage of cirrhosis, there is a chance for, if the patient stops at toxin intake, that is alcohol intake, there is a chance for the liver to regenerate and get back to normal.
Thank you, sir.
Any doubt? Yeah, please.
When we're talking about Gilbert syndrome,
Yeah.
As you said, that it's very common in the hospitals, the patients.
Yes.
So there are a lot of reasons why somebody's bilirubin levels would be increased at certain points. So how do we tell that, instead of Gilbert syndrome, how do we rule out other diseases basically?
Okay. One is, again, coming back to our history, physical and examination. So history, we will see, is the patient having any other symptoms? Understood. Is the patient having symptoms of other than jaundice, urine discoloration, stool, anorexia, nausea, vomiting, wasting, weight loss, any other symptoms? His physical examination, are there any other findings? In the liver function test, a pure Gilbert syndrome, all what you're going to find is unconjugated. If you do the liver function test, you're going to find bilirubin elevated and it will be unconjugated bilirubin. Rest of the liver function, that is your SGOT, SGPT, alkaline phosphatase, albumin, globulin, INR, everything will be normal. Then the next confusion that you could have is, that anybody could have is, okay, the liver function is normal. That means the liver is normal. Could I be dealing with a hemolytic anemia? Right? So we look at the CBC. The CBC is normal. You do the reticulocyte count. You find the reticulocyte count is not increased. That means there is no increased destruction compensation. You do the LDH. Everything. Yes, LDH is not. In other words, except for the fact that you're going to have jaundice and you're going to have an unconjugated bilirubinemia, rest of the examination, physical examination, history taking, physical exam, everything will be normal.
Okay. All right. Thank you, sir.
Of course, the confusion happens when the patient comes, like I said, one more thing, intercurrent illness. For example, this comes to notice when the patient comes to you with normal. All of us right now during this season is developing fever with upper respiratory tract infection, throat infection. So patient comes with pharyngitis and sometimes a routine blood test is done. At that time, you will find this. Understood? Maybe that's the first thing. So you get a confusion. Am I dealing with a jaundice hepatitis? Is it a fever, prodromal symptom, viral hepatitis? But if that is the case, again, what happens is we will again depend on our history physically. In the history, if it was hepatitis, the patient would have not only jaundice, anorexia, nausea, vomiting, other features. So we look at all the using, again, we always the tools are history, physical examination, and relevant lab investigation.
All right. Also, we have learned when we are talking about Gilbert syndrome that treatment was not required except for, I think, a certain drug.
Yes.
So, since they have elevated bilirubin, wouldn't that affect, like, they'll be presenting with symptoms, right? So
no, that's why I said this is just it is not an absolute defect in the conjugate. It's a partial error. So they will only have mild unconjugated hyper. Sometimes, in fact, you will find some of these patients routinely when you keep repeating the test again and again. Some of the times it will be normal, some of the times mild elevation. It could be like on your religious fasting. Some people fast for religious purpose or for whatever intermittent fast. So when you're fasting, the bilirubin can go up. If you're not having adequate stress of an exam or a stress of an intercurrent infection or during a surgery, it can be mildly elevated. This will not harm the patient at all. All the treatment that is required is just explaining the condition to the patient and nothing to be worried about.
All right. Okay. Thank you, sir.
Any other doubts? Aim of my talk was to emphasize what you're studying today is useful in the clinical thing and to tell you that that is the same things what our teachers have taught us anatomy, physiology, biochemistry. We are applying it into clinical practice. That what you're learning today is going to be very, very relevant in your future. Okay. Shall I stop? Any doubts? Shall I stop? Anything else you would like me to clarify, or can I stop? Only with your permission, can I stop? That's fine.
Thank you for your time, sir.
Okay, thank you very much. All the best.
Thank you,
Thank
sir.
you, sir.
Thank you, sir.